of life care from a nursing perspective. Coming to communications with relatives. Communications between ICU staff and patients and their family is consistently identified as the most important and least accomplished factor in the quality of care in ICU. Family members are generally recognized as surrogate decision makers because they are presumed to know the patient's preferences and to act in the patient's best interest. ICU staff not only need to inform the patient or the patient family members regarding the diagnosis, prognosis, treatment, but also need to make help making decisions that reflect the patient goals and also attend to the family emotional needs at a time of severe stress. Multiple studies suggest that communication with family members in the ICU is inadequate. One study reported that half of the family members, even after 48 hours of admission, did not understand even basic information about the patient diagnosis, prognosis, or treatment. Most ICU personnel will say that communication with families is the most stressful part of their job. A Cochrane systemic review of communication skills, training for healthcare professionals working with cancer patients and their families, concluded that communication skills do not reliably improve with experience alone, but training programs with appropriate educational techniques are effective in improving the skills. So coming to the fundamental principles of better communication, there are 4 different types: ask, tell, ask principle, tell me more principle, responding to emotion principle, and finding out the difference between monitor and blunders, and identifying the best technique to address the information needs. Coming to ask, tell, and ask the principle. Here we need to ask we need to ask the family members to describe their current understanding of the situation. This will help us in understanding the level of knowledge, the emotional state, and degree of education of the family members. It also allows us to determine if the family has any misperceptions. It gives us an opportunity to determine the family's concerns and negotiate an agenda for the conversation. Asking before providing information also serves in help building a relationship and allows them to have some control over the conversation. Then tell the family in a straightforward language what you need to communicate, whether it is bad news, treatment options, or other information. Understand that the family is stressed, overwhelmed, so you need to think about 2 to 3 take-home messages that you want to get across and focus on those. Too much information is confusing, and always use 8th grade communication English and avoid using excessive medical terminology. Then at last, you need to again ask the family whether they understood what you have just said. This gives you an opportunity of their understanding, and if any understanding differences are there, you can correct those. Coming to tell me more principle, here this is used to bring the conversation back to the track if it is going off track. To get it back to the conversation, you need to be helpful to invite the family to explain where are they in the conversation. Usually psychologists say there are 3 levels of in any conversation. First level is what is happening to us, where the family is trying to comprehend and understand the information that is being provided to them. The second level is the emotional level. How do I feel about this? And the third level is how is the information that has been provided means to them. So when you understand these, you can try to bring them back to the conversation rather than getting off point. So one of the useful examples of tell me more include, could you tell me more about what information you need at this point? Could you say something about how you feel about what we have discussed? Could you tell me what this means for you and your family? Using reflections rather than questions to learn more. Reflections are restatements of the family's words or guesses at what the family means. These usually serve 2 functions. First, they convey empathy and let the family know that the clinicians have heard what they feel and they are trying to understand their perspective. Secondly, the reflective statements empower the family to take control of the conversations. And thirdly, it allows silence and time for the family members to respond and make decisions. Skills to responding to emotions. Being in ICU typically involves bad news. This is often potential for death. So in addition to that, there is loss of physical function, loss of social function, alteration in quality of life. When faced with this kind of loss, people react emotionally. So there are strong emotions like disbelief, sadness, anger, frustration, and hopelessness. These are common in ICU. First, you need to identify what the emotion reaction to the bad news, and you're more likely to respond with empathy. First, when patients are experiencing strong emotions, the patient attenders are less likely to hear the information that is being provided to them. Second, in midst of strong emotional reactions, people find it hard to make any decisions. Third, when patient want to express strong emotions, it is feel that their situation and emotions are heard and appreciated. And when you act empathetically, patient try to connect with their emotional reactions that gives them important values. Finally, most practical, acting empathetically enables the physicians to create a medical plan that serves the patients better. There is a useful mnemonic that helps in responding and accepting emotions. That is, one is naming which type of emotion it is, understanding the emotion, respecting that emotion, supporting that emotion, and exploring. The mnemonic is nurse. Usually patient attendants are very different. Some people want a lot of information. Some people don't want information at all. So psychologists have identified two types of people. One is monitors, one is blunters. So monitors are who seek very large amount of information. This information helps them manage the situation. So you can help them by limiting the information and generally shifting them towards acknowledging their emotions. People who use emotions for coping are called as blunters. They tend to avoid information and they distance themselves and engage in denial of the situation. Here, shifting them towards information and practical planning can be done with using ask and tell, ask, tell, and ask situations. Generally, we encounter both combination of both blunting and monitoring type of people. Common pitfalls in common and good communication: giving pathophysiological issue lectures, don't force your agenda, not finding out the family information needs and styles, launching your agenda first without negotiating the focus of the interview, offering premature reassurances, pushing the family to make a decision when they don't have a chance to grieve for the loss, feeling you are responsible for maintaining the patient's hope, ignoring your own feelings, making assumptions about the family, what the family knows and does not know, and talking too much. Giving bad news usually requires a coherent strategy in order to be that has to be accomplished successfully. So usually there are 6 distinctive steps that can be summarized as spikes. One is setup. They need some good setup for giving the information. One is perception of the patient's family. Then inviting them for giving a bad news and giving them whatever knowledge you have regarding the patient condition. Empathize with the family. Then finally summarize and strategize further goals of care. Conflicted families, any disagreement is always natural and expected in any part of conversations with the family. Understand that the conversation is not primarily about the information, but about the meaning. We think that the conversation is about the facts that we know and the family does not know. Explore the family's perception about a clinical situation and medical care options. This is crucial. This should be the first step in order to resolve the conflict. Misunderstandings can be due to various reasons, like family has not been told about the situation, family has been given information but not in their language which they can understand, family has been giving conflicting information by different healthcare providers, family received mixed messages, family is obtaining information from multiple sources like Google, internet, other family members, family is seeing conflicting messages from what you are saying, and family is acting out of fear that they are responsible that the decision will cause harm to the patient life. Patient does not trust the healthcare team. Identify the relevant issues and devise a strategy to address these conflicts. Coming to end of life care. The objectives of end of life care is achieving a good death for any patient who is dying, irrespective of diagnosis, duration of illness, and place of death. Emphasis on quality of life and quality of death has to be there. Acknowledge that the palliative care is human right and every individual has a right for a good, peaceful, and dignified death. Components of good death: pain and symptom management, clear decision making, preparation for death, completion, contribution to others, and affirmation as a whole person. Steps involved in providing a good end-of-life care, recognizing the dying process, end-of-life care decision-making process, initiation of the end-of-life care, completing the process of end-of-life care, scope of palliative care in end-of-life care, after-death care, medical care review, and bereavement support. So how do you recognize a patient who is dying? He has a progressive fall in BP, progressive fall in temperature, altered breathing patterns, skin discoloration, bedridden patient with decreased spontaneous movements, cessation to respond to questions and non-verbalization, detachment from surroundings, no interest in food or water, he is in a comatose state, unable to take oral medication, and severe cachexia. Studies have shown that physicians in India are reluctant to consider limitation of life support when they compare to Western peers. This is due to lack of clear legal framework rather than prevalent social and cultural customs. Initiating end-of-life care, clinical criteria, as I said before, criteria of end-of-life care has to be met. Agreement criteria. First, the physicians, all treating physicians have to be agreed. There will consensus that all potential reversible causes have been corrected and the patient is really dying. The family understands that the patient has advanced progressive disease and as a result of that, he is dying. Symptom criteria, at least 4 of these should be present. He should be semi-comatose or comatose, unable to take oral medication, confined to bed, unable or lack of interest in food and fluids, no response to question or spontaneous verbalization. He is detached from surroundings, failing vital parameters. Process of end-of-life care, guiding principles are symptoms should be well controlled. There should be a preferred place of care, safe and secure place for care and further crisis. Caregivers should feel supported, involved, and empowered. Healthcare for staff should be confident and should have a sense of teamwork. Family, it should be prepared well. They should be educated in all the parameters and they should be supported when needed. Coming to the team, it should be accepting and it should be anticipating all the possible complications and should be ready to provide all supportive care. The scope of palliative care in end-of-life care, relief of end-of-life symptoms such as pain, dyspnea, delirium, respiratory secretions, review of existing protocols, review of medication chart, stopping unnecessary medications, stopping routine or unnecessary investigations, continued communication through the process, counseling regarding optimal hydration and food intake, psychological support, and meeting special family requests like spiritual or cultural or religious. After death, information of the death is communicated early and sensitive to the family. The primary team is informed. Body is laid out in culturally appropriate manner. Provide presence and support to the family. Privacy and space to the family. Timely, correct and verification of certification of death and timely dignified transfer of deceased from the hospital. Bereavement care support. First, family identifying the families that need bereavement support. And usually there are specialized medical social workers and volunteers who specialize in this kind of support. And if needed, psychiatric referral and pharmacotherapy can also be used. Review of care process. This should be done in order to know and understand if the care process was complete, if there are any gaps, whether the family received full adequate health-related communications, the family fully understood and accepted the care process, the family has any concerns regarding the care process and was it freely expressed and whether the concerns were addressed. If the family felt supported or appreciated the care process and to assist by the satisfaction of the healthcare providers. And also initiate any improvement needed in the end-of-life care process. Legal pitfalls. There are no legal parameters or policies guiding the clinicians on end-of-life care. There was just one public interest litigation on Aruna Shaunbach case where Supreme Court of India ruled involuntary passive euthanasia was allowed, but not of end-of-life care. Principles of guiding good end-of-life care involve respecting patient choices, consideration of full futility, deliberate consensus decision-making, and moreover, a human touch. Recommendations: full disclosure by the physician regarding poor prognosis and futility of aggressive treatment. Should initiate discussion regarding treatment options, including no specific treatment. If the family desires palliative treatment, they should be offered all available modalities, including full support, do not intubate, do not resuscitate status, withholding of life support, withdrawal of life support, and palliative care. If the family's decision is pending, all existing supportive intervention should continue. Initiation of new therapies should be based on clinical judgment. Clear documentation of all discussions, including the mention of persons who had participated, should be done. It helps preventing future misunderstandings and allows transparency. The overall responsibility is with the primary physician or the intensivist. If the family agrees for life support withdrawal, clinical team is ethically bound to limit the treatment within existing laws. Make sure that effective palliative care is given and also attend to the emotional needs of the family. Palliative support includes adequate pain control, avoiding or minimizing respiratory distress, avoiding psychological stress, control of symptoms, attention to spiritual and environmental needs. So finally, the steps of end-of-life care. Communication is important. Ethical principles needs to be followed. Identify patients for end-of-life care. Assess for end-of-life care. Plan accordingly. Provide end-of-life care. Reassess again and reflect on any gaps in the end-of-life care. These are my references. Thank you for your attention.